Welcome to RAAONLINE. Today we are going to see about interpretation of ventilator waveform. So we all know about electrocardiogram. From this ECG will record the electrical manifestation of the heart. It gives idea about what is going on within the heart, like physiological activity and some disease activity, arrhythmias, all we know from the ECG. Like ECG, ventilator, nowadays the modern ventilators will give the continuous real-time information about patients and ventilator interaction about respiratory mechanics. So most commonly we will see the three waveforms. One is that pressure time scalar, flow time scalar and the volume time scalar. From these informations we can understand what is going on within the patient's lung, how can we adjust the ventilatory parameters, how can I optimize the ventilatory settings to improve the patient ventilator synchrony. So when you see here, but this is the most important, understanding of the ventilatory waveforms are very important to increase the success rate of ventilator related outcomes. But the recent survey showed that it's what published in the 2024, they found that only less than 5% of the ICU consultants are understanding the ventilator waveform appropriately. Almost more than 90% of the ICU consultants are the doctors practicing critical care, not able to interpret the ventilatory waveform appropriately. They are not making appropriate intervention for the whenever they are facing the problem with the ventilators. So the understanding of the ventilatory waveforms are very, very important. So next we see that what are the things, what will you do with the ventilatory waveforms, why we need that ventilatory waveforms, why the modern ventilators will give the continuous information about the respiratory mechanics. From these ventilatory waveforms, we can understand that what is the pathophysiological process. Like whenever the patient comes to you with COPD related, the waveforms will be different, like the auto-PEEP or increased time constant. These are the common problems we will face with the patient with obstructive aortism. If it is ARDS, time constant will be very short. It is a compliance related problem. Our ventilatory settings will be different. So that one. Second thing, recognize the change in the patient condition. So the patients in ICUs are very dynamic in nature. For example, complaints may be normal in the morning, may be worsened during that ICU stay in the afternoon. So pulmonary edema, whatever, they're just simple aspiration. So we can recognize the change in the patient conditions from these ventilatory waveforms. From these information, from the patient change in the condition or pathophysiological process, we can optimize our ventilatory settings. Maybe treatment also we can modify. Example, patient with increased auto-PEEP or increased time constant is a resistant related problem. There some of the COPD patients may need nebulizers or bronchodilators. We can optimize, we can solve new treatments based on ventilatory waveforms. So then we can, that other things are, we can detect the adverse effect of mechanical ventilation from these ventilatory waveforms like auto-PEEP, we already told them. Based on these informations, these appropriate ventilator settings, we can minimize the risk of ventilator induced complications. So then first, how will you read the ventilatory waveform? There is first step is that what is the ventilator is programmed to do, which means that what mode of ventilation you selected for the patients. What is mode actually? What is a mode means that it gives the information about, it's the predetermined pattern of interaction, which means if example, if it is a volume control, your flow will be constant irrespective of the patient resistance and the complaints. If it is a pressure control, the pressure will be, you will set the pressure on the ventilator, it will be the constant irrespective of the patient resistance and complaints. So first thing is that you should know what is the mode, how that mode actually behaves. This is very important for us. It's a step one when you start the reading of the ventilatory waveform. Second thing is analyze the waveform or read the patient's physiology. So whenever that, next you see selected the mode, you know the node, then you look for the ventilatory waveform. From these waveforms, we should know that what normally this mode of mechanical ventilation, what will be the normal waveform. When any change in the resistance and the elastance, how will you affect the waveform? So this is step 2. It's analyze the waveform to read the patient physiology. This actually called as a determine the load. Third is the patient ventilator interaction. It is called asynchrony, synchrony or desynchrony. So we can identify from that. Based on this information, we can optimize the mechanical ventilation settings. First thing is that we should know what the ventilator is programmed to, which means that what type of mode. Second is that analyze the waveform to read the patient physiology, which means that you have to understand what is the predominant load, which is resistive load or elastic load from and the step 2. Step 3 is that is there any asynchrony or synchrony or dysynchrony, you have to identify that. These are the 3 steps of reading of the ventilator waveform.